Welcome back, everyone. I hope you enjoyed as much as I did the last session. The emotional impact of colorectal cancer on patients. I think you had the opportunity to reflect and learn new tips and tools to help deal better with all these emotions. So, in our next session, we will look at personalizing your post treatment care plan. We'll talk about things like bowel functions after treatment, how to reintegrate work, and other real issues encountered post treatment. We're joined by Dr. Marie-Lise Boutros, Program Director for Colorectal Surgery Residency and Head of the Colon and Rectal Surgery Research Program at the Jewish General Hospital in Montreal. Dr. Boutros will share a short presentation, after which we will move to a panel discussion. For the panel discussion, we'll be joined by Elliot Goldberg, Anna Urbani, and Chris Schwartz, all patient and survivors, and Dr. Carmen Loiselle, a psychologist, nurse, and professor. At the end of the session, you'll have the opportunity to ask your question. As you're listening, if you have any question in mind, please do not wait and feel free to add them to the question section on the top right of your screen. With this, Dr. Boutros, over to you.
Thank you very much. It's a great honor to be with you today. This is an area that I'm very passionate about. I'm a colorectal surgeon. So once treatment is finished, now what? Well, we've entered the survivorship phase, and there are many elements in the survivorship phase. Ongoing surveillance, doctor's visits to make sure that the cancer doesn't come back, dealing with the long-term physical effects of the treatment, trying to get healthy and stay healthy, and a wide range of emotions, as Dominique just mentioned. However, each person, as they experience a new normal, will want to kind of get control and see, how can I be living life to its fullest? How do I get back to work and a routine? And how do I deal with the consequences of treatment? With regards to cancer recurrence, it's important to develop a survivorship care plan with your main anchor for treatment, whether it be your surgeon, your oncologist, your family doctor, whoever is going to be following you now for the next 5 years, to make sure that this cancer doesn't come back, and if it were, to be caught at an early stage. Survivorship visits will include doctor's visits, exams, blood tests, imaging, and endoscopy, whether they be sigmoidoscopies and colonoscopies. And these are according to guidelines, but developed also relative to the stage of the tumor that you had experienced. One interesting study coming out of the Scandinavian countries compared high-intensity surveillance, so frequent visits to the doctor with exams in the first 2 years every 3 months and following 3 years every 6 months, to a low-intensity surveillance program where you were checked on once to twice every 1 to 2 years. And they found that both groups did exceptionally well. There was no real added benefit to a high-intensity surveillance program. And so when patients come and tell me, I want to go overseas for 6 months, it would make me really happy. Would that be dangerous if I missed a visit? Sometimes I can alter what their survivorship care plan would be, just to be able to live life to its fullest and achieve the things that they want to achieve. The area of my research, and an area that I'm passionate about, is dealing with the long-term consequences after successful colorectal cancer surgery and treatment. As many of you may know, if the cancer experienced is really close to the sphincter mechanism, we have to remove the rectum with a permanent bag. And there are other reasons why we may need a permanent bag. However, if the cancer is higher up in the rectum or somewhere else in the colon, we're able to take it out and reconnect your bowels, and so to avoid a permanent ostomy. Whatever operation is performed or treatment is performed, there will be a new normal bowel function after colorectal cancer treatment. Whether it's living with an ostomy, so dealing with the skin around the ostomy, the bowel movements, pouching and leakage, and all the emotional and social aspects of an ostomy, definitely will change your life after surgery. Most patients, though, will undergo a resection, meaning a surgery that removes a part of their colon or rectum, and they can have a reconnection. And after this reconnection, patients experience a whole constellation of negative bowel symptoms that increase if the cancer is in the rectum or in the left colon. And these constellation of symptoms include frequent visits to the washroom, urgency, incontinence, and clustering, where people will have a bowel movement, go back into the bathroom, feeling like they need to go again and again and again, and thus taking up big chunks of their time in the day. And these constellation of symptoms are termed low anterior resection syndrome. LARS has become the area of my research and my academic career. So what happens with LARS? Why do we get LARS, or this low anterior resection syndrome? Number one, we're losing the reservoir of the rectum. The colon's job is to absorb water and push stool forward from the colon into the rectum. And the rectum is a reservoir that can hold the stool until it's a good and convenient time to go to the bathroom. When we operate and connect the colon to the rectum or remove part of the rectum, we lose part of this reservoir. In addition, chemotherapy, radiation, and surgery all impact the nerves of the colon and rectum. Whatever segment of the colon or rectum are removed make the passage shorter, and so making more frequent bowel movements. And with treatment, we may alter sphincter function. As clinicians and surgeons, we have in our armamentarium that we can do surgical techniques to recreate kind of like a new rectum, and that can help with the symptoms of LARS. It doesn't make them go away, but it can prevent their severity. And if possible, I try to construct one of these reservoirs. Nonetheless, 7 out of 10 people who have surgery on the left colon or the rectum will experience some sort of disturbed bowel function after surgery. However, people experience it so differently and affects their lives each individually very differently. So this is a really good example of the bowel dysfunction on why post-treatment care really needs to be personalized. And I'm going to use bowel dysfunction as my example because it is my area of research, but it's the same with sexual dysfunction or all the other dysfunctions that can occur after colorectal cancer surgery. It's important to understand the syndrome. What's happening to my body? Why am I having these frequent bowel movements? Is it diarrhea? Is it clustering? Is it incontinence? It's important to notice at what time of day is it really worse? Or is it worse on the weekend? It's also very important to reflect on these symptoms and what's their impact on you. For example, I may be working from home, so my frequent episodes to the bathroom are less bothersome. But you know what? It's that leakage once a month that's prohibiting me from going on a long flight and traveling, which is a passion of mine. So what's really bothering me from these symptoms? It's also important to note stool consistency when you talk about bowel dysfunction. So after surgery and treatment, your stool consistency may change. A type 3 or 4 stool, a nice well-formed stool, is easier to hold on to and easier to evacuate. Diarrhea or pellets are harder to hold in and also can contribute to difficult evacuation. So take a peek. What's happening with your stools? For each person, foods will impact their bowels differently, but there's definitely a connection. Some of the common offenders that patients have taught me are diet, gums and so spicy food, and a lot of fruits and leafy vegetables that have insoluble fiber that usually give diarrhea. Other culprits are alcohol, caffeine, and maybe drinking too much water. Each body reacts differently to these things. So for sure, it's not a one-size-fits-all solution. Once one has understood the syndrome and sort of reflected on what's going on in their body, it's so important to set personal goals. What is it that's bothering me? Well, I can't sleep at night because I get up to go to the bathroom every 2 hours, and I'm afraid I'm going to have an incontinence episode in my bed. Well, I want to get rid of this nighttime bowel movements. Or, clustering in the morning. I'm working from home right now, but when I get back to work from the office, it'll be impossible because I won't have a bathroom beside me. What is it that I want to change and take control? Self-management strategies are really the way to go. They're the starting point for managing bowel dysfunction because only you are feeling what's going on at what time with what trigger food. For me, I can serve as a sounding board. I can listen and think with you once you've reflected and sort of figured out what's going on in your body. Get support from peers, and we'll talk about some of our peer support initiatives, and family and friends. And of course, we, the clinicians, are here to support you through this journey. All right, so some tips for bowel dysfunction. Psyllium husk or Metamucil is a soluble fiber. It's something that your body can digest, and it helps bulk up your bowel movements to make them into that nice number 3, number 4 that you can hold on to or evacuate easily. Bananas, oatmeal are also soluble fiber, unlike the leafy green vegetables and some of the fruits. These ones are actually digested and incorporated in your stools to help you have a bowel movement that you can hold on to and that you can evacuate with ease and no pain. Imodium is an over-the-counter medication that you can use. Some patients love it, and it has completely changed their lifestyle, while other people have said that it constipates them and bloats them and gives them cramps. The way it's used, it's in increments of 1 pill at a time, up to 8 pills, although I wouldn't recommend getting to 8 pills. Using a diary is very important because that helps us put 2 and 2 together for yourself and for your clinician. Okay, it really does look like it's repeatedly the evening that's the problem, or when I eat such and such a thing. Finally, when you make a change, either in your diet or medications, try to wait a whole week so you can see what the impact of that change may be. Other important things are toileting habits. There's a good way to sit on the toilet at a 30-degree angle, feet up on a stool, if evacuating is difficult for you. Because for some patients, LARS is really about a difficult evacuation rather than incontinence. Remember not to spend too much time on the toilet. It is not the reading room. Also, perianal skin care is very important. Because of the frequent bowel movements, especially initially right after surgery, it does get better. But we need to take care of our skin around our anus so that it doesn't break down and bleed and get infected. Other important things are biofeedback exercises, so pelvic floor exercises like Kegels. And if you've already performed that and it's not helping, a biofeedback therapist, a physiotherapist specialized in the pelvic floor, can also help. A study out of China with 175 people who survived rectal cancer found that people who used self-management strategies had much better bowel symptoms, and that the most used bowel self-management strategy was diet modification. Out of the Netherlands, they implemented a program where they screened all patients for bowel dysfunction after colorectal cancer surgery, and they gave people information and tips and tricks based on the things that were bothering them. And they found that their quality of life greatly improved. Here at McGill University and at the Jewish General Hospital, we launched a multi-center trial in North America where we've put together an informational packet as well as a nursing support program so that we can walk the walk with people who are now rectal cancer survivors, and as they develop a new normal bowel function, hopefully with good quality of life. We've included a lot of information about how the rectum works, about stool, and a lot of the diagrams that I've shared with you today, as well as diaries. We transpose this information into an online peer support forum where the information is equally available, but also volunteers who've been through this bowel dysfunction and optimizing their bowel function, learned how to be mentors to peers, and in a secure, confidential forum are now mentoring and supporting their peers who are going through this bowel dysfunction with tips and tricks and just uplifting advice on how to get through it. So at the core of treatment, there are many modalities to improve bowel function after colorectal cancer treatment. But at the core of it is you being empowered, knowing and being given the information, the options for treatment, and setting target goals for how you would like your new normal to look like. There are advanced options like transrectal irrigation and sacral neuromodulation, and I definitely do offer that to patients once we've worked through all the self-management strategies and feel like this is the next step. Most importantly, you're definitely not alone. If there's one thing I want you to take from what I've said, is that you're not alone. This isn't merely a complication of surgery that you're suffering with by yourself. We conducted a focus group with my colleague, Dr. Loiselle, of our patients at the Jewish General Hospital, and they told us that they felt underprepared for their new bowel function, which gave them a lot of anxiety. They felt alone and isolated, as if they were the only ones experiencing these symptoms. And they felt like that we never explained that these symptoms will improve with time, and they felt hopeless in the first few months after surgery. Thank you very much.
Thank you so much, Dr. Boutros, for sharing not only the impact, but the solution on how to manage post-treatment LARS in the day-to-day. So now I propose, let us introduce our panelists, Anna, Chris, Elito, and Dr. Loiselle. Anna, would you like to start and tell us a little bit more about you?
Thank you very much for the opportunity to be able to thank all the people that helped me at the Jewish General Hospital that saved my life really. And it was an experience where I was very, very grateful every step of the way. So my story is actually a very happy story. So thank you so much. So my path to finding solution was a little rocky because I had no support from peers like has been developed lately, which is great for other people. I think this is the key for finding solutions that resonate with other people that have LARS. And that really, really helped because I did find online, it was on another app. And actually, peer help was amazing. And I found a way to cope with everyday challenges. My challenge was really going to the bathroom from morning to night and at night also. So it was really hell. And with the solution, I just have a normal life, even better than before I had my rectal cancer. So thank you so much for your help.
Thank you, Anna. So maybe Chris, do you want to introduce yourself quickly?
Chris Schwartz, and I'm in my 4th year survivorship. I must say that I haven't had the privilege or the opportunity to know all of this information beforehand. I will say in Kitchener, our cancer center is very good at taking care of us as patients, our symptoms, but when the information of when you're done your treatment, it's like falling off the cliff. And I wish, and this is why I'm such an advocate and want to be part of this, to get this awareness out, to support people. Because as I was listening, I could relate to everything and wish I had talked to somebody or knew, because you feel very isolated. When you have these symptoms, you're not sure what to do. You don't have control of your body at times. I will say I had many a time sitting on the bathroom floor just trying to have my bowel settle down, and I didn't know what was wrong. So if you kind of felt normal with that or knew, it wouldn't be so bad with that. So I really look forward to learning more and being an advocate and sharing my experiences with this, of what we go through. And especially for colorectal cancer, because I do believe it's quite a quiet cancer. People don't realize, especially as female, when we say we've had cancer, they immediately assume it's breast cancer, and it's not. So it's a different sort, and it's a way of treating. And the more we advocate and the more we become and support each other, the better it becomes. And for sure, it can be treatable sooner.
Thank you so much, Chris. Elito, do you want to do the same and introduce yourself?
Sure. It's Elliot, by the way. I was diagnosed in 2016. In fact, in 4 weeks, it will be 5 years since I was diagnosed, or since my operation. So I'm reaching a milestone. At the time, very reasons available. So we all have to be very thankful and grateful for people like Dr. Boutros, who took it upon themselves to try to make all these issues, the whole concept of LARS, to let it be known and to become an advocate for a lot of patients who did not have the resources. I remember when I was finished my surgery, I really didn't have any resources. There were no resources at the hospital, that's for sure. And that's why I have decided to devote some of my effort to this disease and to LARS and the symptoms. I was very fortunate in that I was on the right side of Dr. Boutros's slide there. I was in the 30% that had very, very few problems, and I'm thankful for that. But I do know there are many others who have tremendous difficulty, and it's great to see that there are now resources available to them to sort of figure out that they aren't by themselves. There are groups, there is support, and I think we all have to be very, very thankful for that.
Thank you so much, Elliot. And apology, I had a typo on the name, so apologies for that. So maybe now, Dr. Loiselle, do you want to introduce yourself? And then we'll go to a little bit of a discussion.
Psychology. And what I'm very interested in is ensuring that we support individuals with cancer as best as we can. And I think Dr. Boutros' example really is a genuine approach to person-centered care, so that we're tailoring and personalizing care based on what people feel or what they report. And it's very much an approach that's from the ground up rather than top down. And I was fortunate to be part of Dr. Boutros' team, and the things we learned that really change how we develop interventions came from patients. So one example was then when Dr. Boutros mentioned the focus group that we ran, some of the people were saying, oh, I didn't even know there was a name to all the symptoms I was experiencing. So they were really relieved to know that LARS was something like a cluster of symptoms, and that was something that could be helped. And that gave them a lot of hope in terms of reducing social isolation because of some of the symptoms they were experiencing. So this is actually a real nice juncture where we're really bringing the physical aspect, the psychological aspect together, and making sure that we approach patients' quality of life from those different angles.
Thank you so much for sharing, Dr. Loiselle. So maybe to kickstart a little bit the discussion, a question to ask to the patient. What really kind of after being post-treatment, what changed the most after your treatment? Who wants to start? Elliot, do you want to start?
I can start. I think for me, what changed most for me, I think it was the transition from staying with the cancer center to my doctor. And it's not in a negative way, it was just lack of information. I love my family doctor. I've had her for a long time, so I had a good relationship, but it was that transition of information of what does she need to do? What test does she need to do? It was a little bit of a loss until we got it all figured out with that. But in the end, it was that support part that was really missing. Having advocates, talking to other people who have gone through the same thing to know what was to guide you through it. There's many of days trying to figure out, am I normal? What's going on? And I did find a book that I really enjoyed. It's called Picking Up the Pieces. And that kind of guided me through because there wasn't a lot of information.
Well, thank you, Chris. So I understand, like, again, it was the transfer of maybe kind of that unknown of the patient. Dr. Boutros, you want to say something?
Yeah, absolutely. I hear you, Chris. It's really nice to meet you and hear your opinion here. It's wise. Dr. Loiselle and I are also working on a similar program because I think you're not alone. The family doctors are so invested in your health, and then we sort of disappear from their sphere for this really complicated treatment that's highly specialized, and then you reappear in their sphere. And we're working on a program where we call it shared care so that the family doctor can come along with us for the entire ride and be part of the complex care. So we, the specialists, are like me, I'm very much at fault because I run behind in my paperwork and I don't send letters back to the primary care doctors. So we can keep them in the loop. And part of this program we're developing is also a packet of information about colorectal cancer survivorship, the symptoms that people may experience, when the surveillance should be, what the surveillance should be, things like that. So to address this concern. So I think it's probably shared by a lot of people that they sort of feel dropped back in the lap of someone who this is highly specialized for them.
That's great to hear, like the offering of continuity and the work that's being done to offer that continuity to, I guess, reduce the fear and the roller coaster of emotion in this instance. So this is one of the things that has changed, but is one of you kind of want to share also how more specifically to what Dr. Boutros was saying, your bowel function changed and how you reacted to all of these change?
I'll go ahead.
Go ahead, Anna.
Okay. Yes. So yeah, it was. I was warned by one of my friends who went through the same thing as me. She was 8 months ahead of me, if we can say that. So she explained every step of the way, how she reconnected with, how she managed everything. So I had like a little insight of what was coming. And I really, really considered keeping the bag, knowing all that she was telling me. But I was hoping, like Elliot, that I would maybe not be as bad as she was. And it was horrible. It was terrible, terrible, terrible. And I just stopped eating altogether and say, if the food is the problem, then I'm going to stop eating. So I ate one thing once a day, and it was even worse because I was just burning. It was just the body fluids I was passing, and it was even worse than when I ate. So I had a very long journey of learning how to manage this. It was a shock. It was a real shock. But I managed with help, with peer help, really.
Yeah. So Anna, yeah, that's a bit what you said, but again, how did you overcome these challenge?
Specifically? Yeah, for me, what worked for me is enemas. Like every day, I do enema at one specific hour of the day where my bowels are quiet and calm, and I'm free for 36 hours, and I'm done. No problems, no accidents. It's been 3 years, not once. So I really managed with that.
I see you nodding, Dr. Boutros. Was there anything that you wanted to share on that mechanism to cope with the post treatment effect?
Yeah, I'm glad that Anna found this remedy. I'm sad that you had to find it on your own. And so I think now that we're more informed, in Europe, they're using it very early on because the first year, I'm not sure, you guys can tell me your experience more, but what we observe is that the first year is really the worst year. Things get better slowly, months at a time, and plateau maybe at 2-3 years. And so in Europe, they're using enemas as far early as after 1 month, because if you think back to the first month, that was the horrific month, where things were extremely terrible and people are not sleeping. They're not going out of the house. So They're using enemas early on, which us as surgeons are a little reluctant to have manipulation down there, but they've shown that it's safe and feasible to use enemas and fancy irrigation devices early on. So something we're trying to adopt more and more now, and hopefully we can share with more people that have had surgery. So I'm really glad you found it, Anna. I never knew really what worked for you, but it is definitely a great solution, especially for people who have a connection very close to the sphincter. The lower the connection, the more difficult the symptoms are.
Okay, thank you for sharing, Dr. Boutros. Maybe Dr. Loiselle, any best practice or tips you can share again, on the discussion we're having right now?
Well, one thing that we've noticed is that often managing symptoms and side effects is not done on someone's own agenda, but really shared with either a caregiver, a partner, a friend, like someone just mentioned. And we're really trying to create a network that's more informal also, so that people can help each other. And I think it became more evident again when we had that focus group that many came accompanied by someone. So I would say that, having what we call sometimes a navigator or patient as partners, partnering together, and really absorbing information that sometimes is complex, or sometimes the timing is such that it's challenging to hear what the surgeon has to say, what the nurse navigator has to say, and bringing someone along and really managing it together really is helpful. So I would encourage people to bring along someone. It really helps. Yeah.
So it's going back to you're not alone, but also don't stay alone, making sure that you always have someone. That's great. Maybe before we go to the Q&A, Elliot, could you also share a bit for you what was what changed the most after your treatment? What was the biggest impact for you?
I was very fortunate in that I suffered LAR symptoms for about 3 months post reconnect. And so it wasn't all that difficult. I had a really relatively easy time with all this. And for me, I quickly figured out, and when I say quickly, it took months. Quickly for me was months. I figured out what foods were causing issues for me, and then I changed my diet. However, even today, I still eat some of those foods that cause me issues because I enjoy them so much, but knowing that I will suffer some consequences. That for me became my new normal, as Dr. Boutros referred to in her presentation.
So again, thank you so much to all of you. Thank you for sharing so candidly your stories. We will now open the floor for questions from the audience. And for this, I will turn the MC role over to Hannah Cohen, who you met earlier today to lead and she will be leading the Q&A session.
Okay, well, thank you very much, Dominique, and thank you all very much for for your open and honest responses. Dr. Boutros, phenomenal presentation. Thank you. Very informative. So first of all, I just want to introduce myself for those of you who weren't in attendance in that first session today. I'm Hannah. As Dominique said, I'm a patient and caregiver support counselor at Colorectal Cancer Canada. I am myself a stage 3 colon cancer survivor. Elliot, you're nearing me. I'm at 6 years now, NED. So yay for all of us, right? So it's a real honor to be in the presence of all of you, and the very patient-centered approach that I see here is inspiring. So thank you for that, Dr. Loiselle and Dr. Boutros. My first question, the first question, I guess, would be, I think I'm going to put this to the doctors initially, is how can our healthcare system ensure that a patient's personalized care needs are addressed?
Should I tackle this one? I think it's pretty simple. Ask patients. I think healthcare providers are so used to having the answers, but really, sometimes it really pays off to ask something as simple as how much information do you want to know about your follow-up care once you had treatment, surgery, and all of this? Do you want, to be really involved in some of the decisions that you have to face when you're in the survivorship phase? So I think asking quickly, how much involvement do you want to know, do you want to be in? The second thing is, and that's truly a person-centered approach, when you start where the patient, you meet the patient where they're at. And once you meet them there, if someone says, look, I don't want to be that involved, I have other things in my life, or I don't want that much information, it gets me really anxious, then I think healthcare providers can work with that and not just say, oh, this person wants to be passive, doesn't want any information, so I'll just leave it. Because we know the research says that if people are more actively involved in their care, they have better health outcomes. So I'm not saying, oh, if they're really passive, just let them be. But if you ask and they tell you they prefer to be passive, then healthcare providers can find a way to bring them in, to engage them in their own care, because they know that they will benefit. And alternatively, those that are really, really intense and active and they want to know everything there is and they want to be involved in every decision, we can also, engage them in a different way and saying, look, we're here to support you too. So don't feel like you have to take it all on your own. And that will also reduce the burden of those very proactive patients. And I think those are two examples of how you tailor care to the person's preferences while thinking about them in the long term.
I think that's a fantastic response, Dr. Loiselle. Thank you. Just sort of as an adjunct to that question, in the age of COVID, it's increasingly difficult for patients and caregivers to find support. And especially informational support, you talk a lot about the overwhelming amount of information that patients get. And I can certainly attest to it, as I think, the three other panelists here as well. In that sense, I mean, what would you suggest, and what have you seen in practice over the last year during COVID that really is a good response for patients and caregivers to be able to join with healthcare teams? Have you been able to identify practices that people can institute in order to not be alone, even though they're alone in the doctor's office?
Well, maybe just
and that's a question for anyone. Yeah.
Yeah, just one quick point. COVID has taught us that virtual support works really well for most people, or if it's not virtual, it's the phone. And what we found is that when you encourage people to come together whether it's a medical consultation, they're all like as a support group, people learn so much from one another. So with the technology, just like we are right now all together, it's so easy to bring patients together and say, okay, you're sharing your experience and tips. And so it becomes much more collective when we try to support each other. So I would say that COVID has taught us that this is actually really quite easily implemented, and we should take advantage of this.
Absolutely.
Response.
Yeah, absolutely. We are actually doing online peer support for this low anterior resection syndrome. And that's kind of how we had planned it, but it launched at the beginning of COVID. And it just kept us together and was a perfect platform for people to engage and network with each other. So absolutely.
Okay, thank you. I'm going to put this question to the patients. Anyone can sort of answer. But we asked how the healthcare system can ensure that patients' care plans are personalized. Can you give us an example of something that you did advocating for yourself, and what worked? What did you find was successful in terms of making sure that your specific needs were addressed by your doctors? Sure, go ahead, Anna.
So the problem is that we don't know that we don't know. So
Okay.
maybe just put out there all the possible problems that could occur would be very helpful. And as we go to the doctor, we have that little scale where we can put how much of each symptom we suffer. Maybe put like a scale of everything that could possibly go wrong after the treatment, and so that we are a little bit prepared. That would be my suggestion.
Okay, great. Does anyone want to add to that?
For me, I think I just want to add to it is that the resources for colorectal cancer, making sure all of our cancer centers know about it and know how we could reach out. From my experience only, it was very new and there was not a lot of information out there. So like you said, we don't know what we don't know. And some of these symptoms, you feel just very unnormal. You don't understand what's happening to you. You think it's just you, but in the end, you learn and you go, oh, okay, that's a part of it. Oh, okay. Just even knowing that's a part of it, mentally, you can cope a whole lot better instead of with the healthcare. Sometimes they just think you're complaining about symptoms at times. I'm not saying cancer centers they took it very seriously. Sometimes the family physicians are going, oh, okay. An experience. I kept my medication for my, it wasn't constipation. I had a lot of diarrhea that would go through me. They gave me a prescription for it. I carry that when I travel because I am so scared of eating something that's going to knock me out for 2 days. I don't need it sometimes, but sometimes I do. It stops it in its tracks and makes me feel a little bit more confident. So it's really getting that information out to the centers, to the doctors. We don't ask the doctors know everything, but if they'll say, oh, here's a great resource, this will tell you everything about you, or to ask more questions and to be able to get engaged. And I'm hoping with COVID that when we do reach out, we can get those answers a little bit quicker, or the resources that are at our fingertips.
It's a great response, Chris. Thank you. And again, I love that. We don't know what we don't know. So we do, it's a lot of pressure on the shoulders of our doctors and our healthcare providers. But developing publications and again, organizations like Colorectal Cancer Canada, we do our best to really address sort of like the broad spectrum of what patients need to know. Going to shift over, one question that came in was, how can one mitigate the long-term effects of food passing through the body so quickly from a nourishment perspective?
Would you like me to start that conversation?
Sure, Dr. Boutros.
The colon's job is really water absorption and minimal nutrient absorption. Most of the nutrient absorption happens in the small intestine. So don't worry from a nourishment perspective about things passing really fast through you, but it's extremely annoying and disruptive to life. So the nutrients are absorbed in the small intestine, and then the water is absorbed in the colon. The stool is passed through and it's housed in the rectum. So I see another question in the chat, and I'll try to address both in the same response, is if we remove part of the rectum, that's when the frequent bowel movements start happening. When we remove the colon, which is what someone else was asking, we don't have that water absorption. So stools are looser. So that's a little bit about what's happening. What can we do? Because it's the frequent bowel movements are extremely troublesome. Our patients here will probably have a lot of tricks for you, but a lot of it has to do with the food and the drink we intake. So high fiber rich foods will make you go to the bathroom more frequently. Sometimes we think drinking water is good, but too much water in our diet will make you also go to the bathroom more frequently. These are just simple things to say in a minute's time. And for patients who have, if you've had a subtotal colectomy, as the question asks, you can definitely use some of the strategies that were discussed for Lars, because you've had a connection to the upper rectum. So again, your bowel movements are disturbed. I hope that addressed your question.
Fantastic. Yes, very, very well said. I actually, I see we're getting low on time for the question period, but this last question is going to go out to the patients. What lifestyle choices would you say have contributed to your success in the post-treatment world?
So if you don't mind, I'll take a stab at that. So for me, there was not much change, but the fact that I got back to my office within 3 days of leaving the hospital and returning to figure out what the new normal was going to be for me. I'm a cyclist, a very avid one. So getting back on my bike and figuring what I could and couldn't do, or what changes I had to make as a result, were very, very important to me, and created that new normal that Dr. Boutros spoke about a little bit earlier as well.
And quick, be kind to yourself when your body doesn't react the way you want it to. Take it one day at a time.
Wonderful advice. Thank you so much, all of you. For your participation. Join us now for a 10-minute wellness break with Debbie McCubbin, who will be taking us through a guided meditation exercise. And following the exercise will be our last session of the day. Join the conversation, building a more resilient healthcare system. Very timely. We're looking forward to seeing all of you there. Thank you.